Thank you for inviting us today. Can I just have a show of hands of the audience who are actually clinical as opposed to research? Excellent. This is going to be slightly interactive, so see if... don't worry, not under the microscope. You're not being filmed, I'm being filmed, so just voices from the audience. Thanks for inviting me. Today was really just to kind of expose you to what sports medicine is, what a sports physician does, what we do at Pure Sports Medicine, and also to go through some clinical cases. All the cases we're going to do are real cases. So you as GPs would get these walking in the door, and some of them have been presenting exactly that way. The idea of looking at musculoskeletal medicine, which is not necessarily orthopedic and surgical, which is a whole trance of patients that may walk in your door. As been said, I started life as a GP, was a full-time GP for about 11, 12 years, and then got involved in musculoskeletal medicine, got quite interested, and eventually took the leap of faith and left the NHS to become a private sports physician. It wasn't an easy decision. I trained before a formal system of sports physician training started, but now there's a sort of 4-year training scheme which involves general practice, it involves exercise medicine, which I'll come into in a second, and obviously musculoskeletal injury assessment and rehabilitation. There are probably about 50 recognised consultants nationwide now. So these are people who have trained and then have got GMC recognition through Article 14, PMET-B, or through the 4-year training scheme. And unfortunately, there are very few NHS posts as sports physicians. So a lot of these doctors either drop back into general practice or work as private sports physicians, which is what I do. So whichever route you take, if you're a slightly older like me and missed out on the formal training scheme and did your own formal training I did it through Bath University, the idea being is to produce what we call a sports physician, but actually in reality is an orthopedic physician. So we don't do any surgery, but we look at all the musculoskeletal injuries that happen that actually are never going to need surgery, and that's a fair majority. And our training is such that it's a three-way workload. Obviously, by far the most is clinical workload. We see cases of people injure their knees, shoulders, necks, backs, ankles, whatever, and we try and deal with those. There is a component where quite a few of them, doctors, might want to work with a team. That's where perhaps you get a bit of exposure, a bit of elite medicine, a bit of buzz, a bit of challenge. And I would suspect that most of my colleagues have explored that avenue. I spent 10 years with England Rugby in all, 5 years with the senior team, and that was quite encompassing. The last 4 years of that job, I was away from home for 23 months. So it was quite an involvement, and it was a seven days a week job. Although I wasn't necessarily with the team, a coach would ring me up at any time of day or night and say, what's the latest injury with so-and-so? Why did he come off the pitch today? What's going on with him? How long is he going to be out? Can we play him? Things like that. It's very relevant now because, obviously, if you're interested in rugby, they're playing this weekend against New Zealand, and there are injuries happening all the time. And the third factor of sports medicine training was actually quite important and be relevant across the board of the audience here, is actually exercise prescription and healthy living. And this is where I think the government have missed out. The people in my field are trained to deal with how to prescribe exercise and where the role of exercise leads into chronic health and illness. So actually, lots of money is being pumped into drug therapy for depression, cardiac disease, chronic disease, diabetes, obesity, hypertension, where actually there's a case for saying that a lot of that cost could be saved by actually getting people to exercise more constructively, more prescriptively. And I'm not too sure if the government are getting their head around that because they don't really know where we fit in. But there's a lot of potential savings here. And GPs, I know, there's a concern for GPs, I understand. How do we get our patients to exercise without putting them at risk? Where do we get that done? How do we prescribe it? And it is a challenge. And exercise on prescription has been around a long time. But I think there's an opportunity for the wider field of maybe less active people who can actually improve their morbidity issues and risk factors. So that's our training. How to deal with the elite, how to deal with injuries, and how to prescribe and see the benefit of exercise. So we look after those musculoskeletal problems that are not inflammatory. I'm not a rheumatologist, and that are not surgical. I'm not a surgeon. And when I was a GP, I think it's probably changed now, but I was told 30% of the workload is musculoskeletal. It's probably about 5% now with all the other demands that you have. And of our workload, and we see a lot of patients, we have 4 clinics throughout the whole of London, less than 5% actually needs to go to surgery, which may be appropriate. So we're seeing people that never need to see a surgeon, but have a problem that stops them from doing either their job or their pastime or their hobby or their area of expertise. And we have a mixture of team members who can deal, the idea being is a one-stop shop. So they come in with their problem and the various components of rehabilitation are all there together to allow them to move on to get back to what they do. So this is how pure sports medicine was evolved. Set up by a non-medical person who came from Australia, who's an ex-Australian sevens rugby player, came to London, to Oxford to do an MBA, and within the first week accidentally ruptured his Achilles. No problem, he said. I'll go to the sports injury clinic. And everyone looked at him and said, not too sure we have those here. And he said, well, we have loads of them in Australia. They sort you out. He said, well, yeah, you go to casualty like everyone else. And so thought, hang on, there's an opening here. Replicate what happens in Australia. And so business plan, one thing led to another. 10 years later, we have 4 clinics in London, stretching from Rains Park to Kensington to the city to Canary Wharf, where basically they're replicated in that multidisciplinary team that looks after a variety of injuries. So any of these as a sort of global dip into the plethora of injuries, but this is what things we see. And these are the team members we have. So we have sports physicians, orthopedic physicians that would help diagnose and coordinate your rehab, very much like a GP would on a variety of things. But physiotherapists, pretty standard. Strength and conditioning coaches. A lot of patients have injuries, they get weak, they may be repaired from their injury, but they've lost their strength. So they need to then be reconditioned for their sport, for their activity. Massage therapists would be there to shop tightness and muscle tone to try and get them back into activity. And we have podiatrists, osteopaths, nutritional therapists, and support staff, all there to try and look at the various aspects to get these patients back. So going on to musculoskeletal injuries, it's pretty straightforward. I mean, if orthopedic people can do surgery, we can certainly do the non-surgical side. And you can divide the injuries we see into 1 of 3 types. Trauma, be it acute or chronic, and that's pretty straightforward. They would walk into your clinic, I've hurt my thumb, I've hurt my neck, I've fallen over, I got tackled, I fell off my horse. Pretty straightforward. But overuse injuries, I'm not too sure if you're familiar with those. These are cases where people would come in without an injury, but they probably overloaded their body that's not adapted to cope with it. So the classic would be someone who's decided they want to start running the marathon or half marathons. They do a bit of running and build up their load and realize for whatever reason that they start getting Achilles pain. And is it because their biomechanics are poor and therefore they can't cope with the load, or is it because they're not strong enough, or because they've suddenly jacked up their running load or started to do some hill running, or someone on the internet or a personal trainer said, let's do some of this, and their body says, whoa, hang on, can't cope with this, and they start getting problems. That's an overuse problem. Or obviously, as we were all taught, have they got knee pain which is referred from somewhere else. So it's pretty straightforward. I very rarely see anything other than that. Obviously there are some medical conditions and inflammatory conditions, and I would refer them on. But we see these sort of problems. Obviously soft tissue injuries, muscle injuries, fascial injuries, ligament injuries. We see tendinopathies, stress fractures, Patellofemoral Syndrome, osteoarthritis pubis, and we're not confined to elite. We do see a lot of elite players, but not a vast amount. And we're dealing with people who just want to enjoy their life and be active and get on with their hobbies. So that's what I do. Any questions on that? Any questions about our clinic? Okay, and as I say, we've got a variety of doctors and team physicians, and these are just a catch full of what clubs and associations we've had dealings with. Okay, the rest of the talk is going to be clinical cases. So feel free, I know you're eager, Feel free to ask questions. If you don't want to talk about this and want to ask something else about anything clinical, happy to have an open forum. Just let me know what you want to get out of this. So I'm going to present some real cases, present the history, present the examination, ask you what your thoughts are, any ideas, what's going on, and talk about cases. So, patient number 1, 58-year-old diabetic, keen recreational swimmer, presents with a gradual onset of deltoid region shoulder pain. No history of injury, so didn't fall, didn't twist. It's very painful. Night pain, by which I mean they can't sleep. They're woken up by pain, rolling over in bed, walking the bedroom. This is uncomfortable. But no neck pain, or what I would call radicular symptoms, which are pins and needles, numbness, shooting pain from the neck. So we're not really thinking it's coming from their neck or referred, but they've got localized pain. Any thoughts on that? Just absorbing and taking it in. Okay, so you examine them, and I appreciate I have a lot more time than you as GPs would have, but their neck is normal. They have very limited range of movement of their shoulder. So flexion is only to about 90 degrees, abduction to about 80 degrees, and external rotation is very limited. They have poor scapular rhythm. Are you familiar with the term scapular rhythm? When we move our arms, obviously the ball and socket are moving, but our scapula, which hold the ball, the socket, are moving up as well. Tonight, when you get home, get your partner to take the top clothes off and get them to stand facing away from you and bring their arms up like this. And you should see their scapulas moving equally like that. So the cup is pointing northwards. Without that, we'd only be able to bring our arms up to here. So as we move our arms up, the cup moves north and we bring our arms up to the sky. With me? Now, ideally, that should move smoothly, both sides, symmetrical. But if it doesn't, then obviously something's happening to the ball, which is not a socket, which is not allowing it to point north. And the whole process of scapular-thoracic rhythm is how it moves aside. So on this patient, I can't remember what side I said, but on the affected side, it's not moving. It's either juddering or jerking up forwards or coming out away from the thoracic, which means there's something going wrong with the actual ball and socket communication. They have good rotator cuff power within the range. So obviously they're limited in range, but when you test their power of the rotator cuff muscles, these are the muscles that are holding the ball in the socket, stabilizing, seem to be nice and strong. And they have impingement, but no instability. Everyone understand what impingement is? Do you want me to explain? Fine, good. Now, when I was a medical student, I was taught that, shoulder problems, you talk about an arc of pain, which means basically as you bring your arm up, it seems to be fine, fine, oh, painful, 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 painful. Oh, that seems a bit easier. And that was therefore told to be bursitis, and I'll come on to what that means in a second. But in effect, what we're demonstrating there is what's called impingement. So you have, as I say, a ball and socket joint. The other ball and socket joint is your hip, but they're very different. The hip joint is a small ball, big cup, inherently very stable joint, relatively limited range of movement, doesn't come out of joint very easily unless you're involved in a car accident. The shoulder is different. Shallow cup, big ball, massive range of movement, and inherently unstable. People dislocate their shoulder far more than they do their hip. To work properly, as I say, the cup has to start moving north and the shoulder with it. But to work efficiently, the ball has to work concentrically within the cup, a bit like a sea lion holding a ball in its nose. So as you bring your arm up, the ball should stay concentrically aligned. If for any reason that doesn't work, then what usually happens is as you bring your arm up, instead of it rotating on its axis, it rises up. And it impinges the structures between there and between there, which gives pain, usually, to the deltoid region of your shoulder. Not on the shoulder here, usually here. And that is called impingement. And what is impingement? As we say, if we look at the ball there, and that's the bone above it, the acromion, usually between the ball and the socket is the supraspinatus tendon and the subacromial bursa. And the theory was that as it rose up rather than rotating away, it bruised the bursa, inflamed the bursa, and you got bursitis, and you therefore got pain radiating to the deltoid region. I had a GP partner in general practice who was very confident, should I say. Some would say arrogant, but confident. And in our practice, we had very strict personal lists. Patients would only see their doctor and could not see anyone else unless he was ill or away on holiday. So we had continuity of care. And we spoke about this many, many years ago. And he said, oh, I'm good at shoulders. I said, okay, yeah, you are, yeah, whatever. He said, I'm really good at injections, really good. Because when I have a patient who has a painful arc, I inject the bursa and they don't come back. I said, oh, great, great. What he didn't know was the patients usually got better because their pain went, because they got impingement and therefore the bursa is inflamed. And so he injected the bursa, which took away the pain, but he did nothing else. So he hadn't addressed the underlying cause of what was causing this impingement, everything rising up. And so after the anaesthetic and the cortisone wore off, the patient got their pain again. But they're always too scared to go back and see him. So they said, wait until he was on holiday and go and see someone else. So we said, yeah, you're pretty good at injections, but you've only half treated, because you haven't treated the cause of the impingement, which is the crux of shoulder problems. Because if you don't treat the cause, the problem will keep on coming back. So what is the cause? And this is where the problem with shoulders arises, because it's not straightforward. And there are many reasons that actually cause the ball to rise up. For example, it could be scapular movement. We talked about how the shoulder blade moves up, but if there's something wrong with that scapula, let's say you've had trauma to the muscles around your scapula, or you've had a problem to the long thoracic nerve where serratus anterior isn't working, which can happen out of the blue and as a result of winging scapula, the scapula won't move properly. So as soon as they bring their arm up, they'll bang up. They could have capsular restriction, by which I mean either because their posture is forward, and we see that a lot in sport, so in rugby all the time, partly because the boys had to get strong, so they did a lot of weights, but also they quite like the idea of having big pecs and big biceps. So they used to work all the time on their anterior muscles rather than their posterior muscles. So side on, instead of being upright, they came forward. And what happens then is if you're looking side on at the gap between the humeral head and the acromion, as you come forward, it closes down. So they're more likely to impinge. And they also get tight into their capsule at the back and tight into their pec, which pulls them forward. So that's purely postural. You wouldn't want to inject that. You just loosen them off and stretch and they'd be fine. But also you see it with other capsular restrictions. Sure, you've all seen frozen shoulder. That's an extreme version. But actually what happens then, in the simple terms, the capsule around the shoulder joint is almost vacuum packed down onto the shoulder and pushes the shoulder up. So they impinge. Are you getting the idea of what I'm talking about? What else could be wrong? Yes, sometimes you're born with abnormal acromion. This bone sticks down. Or you've got where you fall on your shoulder and you injure your AC joint, and that develops arthritis, and you develop a spur that sticks down. You're narrowing the gap between the two. Or you could have had some instability. You could have dislocated your shoulder. And the thing about the shoulder is, because it's so unstable, you have an additional security system, which is called a labrum, a cuff round the cup, which makes the cup a little bit deeper, but also supplies negative pressure onto the humeral head, a bit like a toilet plunger, sucks it in. Now, if you tear that, you lose that negative pressure, which some say is about a 30% of your stability. So the shoulder is now wobbling around. It's lost that stability. So again, it's more likely to impinge. You could have torn the rotator cuff. These are the muscles that coordinate the movement of the head. A bit like having a tent with guide ropes in a wind. Tent post is upright. If you cut one of the guide ropes, tent post falls over, doesn't it? Same thing happens. If one of those rotator cuff muscles aren't working, then you've lost that control, and as you bring your arm up, it impinges. Or you can have nerve problems. So what seems straightforward, and to my partner in general practice, oh, it's straightforward, they've got impingement, they've got a painful arc, we inject them, they go home and we're all better and we're fantastic doctors. Actually, And when you look into it, you think, oh my God, we've got all this stuff to look at. Christ, how am I going to do that? It could be any of those, or a combination of them. And I've only got 7 minutes to see a patient. And they take 5 minutes to take their shirt off. So it's a challenge. So let's go back to our patient. I've got lots of cases. We're going to run out of time. But OK, what was in the history, which might be pointers? You might be able to diagnose this without even examining him. He had night pain. Anyone know of any causes of night pain? This is not, oh, it's a bit awkward when I go to bed. It's, I'm woken up by my pain. And shoulder problems. Any ideas? Anyone want to kind of randomly shout out, sort of, frozen shoulder? I can think of 3. Anyone got any? Almost, yeah. We've got a rotator cuff tear. So the supraspinatus or one of the other rotator cuff parts might be torn. That bizarrely keeps you awake at night. Frozen shoulder or adhesive capsulitis was mentioned, great. Or calcific tendinopathy, calcium in the tendon. It's very uncomfortable. So you know if they've got true night pain, not that it's a little bit awkward when I go to bed, doctor, but actually it wakes me up, then actually you're starting to narrow it down. What about when you examine them, they had reduced external rotation? And don't be put off when you examine them. If you say to someone, right, can you do this? They go, yeah. And they say, oh, that's fine, tick. Actually, stand behind them and do it yourself. And they say, oh, never noticed that before. Because people compensate. So you're looking for, is it restricted in terms of they can't do it, active, or is it you can't do it either? And when you look at it, I just can't get it out there. It seems to be stuck. So what about the causes of reduced external rotation? Any ideas? Frozen shoulder. There seems to be a theme here now. I can think of 3. The others aren't quite so obvious, but a posterior shoulder dislocation, and I think you'd know that in the history, and also osteoarthritis of the shoulder, where it's just completely frozen up, as in jammed up. So we've cursory examined them, and from the history, we think we've got a frozen shoulder. Reduced external rotation, night pain, and they're impinging. Yes, you might want to grab their shoulder and see if it's stuck. And it is. It's passively restricted. So what would you do with that? I mean, I'm sure in your years of general practice, those of you who work in clinical care have seen at least several of these. They're pretty disabling. Patients look horrendous. They haven't slept for months. You've got to do something, doctor. This is horrendous. What would you do? Historically, when I was a young lad, we used to send to the orthopedic surgeons who used to kind of put them to sleep and wrench their shoulder around to try and get it moving. And if they tore the capsule, that was helpful. Yeah, physio is a good suggestion, but actually the physios would say they can't do anything with this initially. Yeah, that might help with the pain, because it's usually have an inflammatory capsulitis. As I said before, the capsule, the bubble of cling film that's around the ball and socket joint, in effect, has become inflamed and is vacuum packed down onto the ball and socket joint. So they're stiff, but also when they try to bring it up, they get that, because they can't move it, but they're also impinging. Yeah, you might want to inject that into the ball and socket joint to release the inflammation of the capsule. But the problem is that it's stuck down. And one very effective way of treating this is what's called a hydrodilatation injection, which is basically injecting a bit of cortisone into the shoulder to calm the inflammation down in the capsule, but a high volume of water to lift the capsule away. And it's a little bit like a eureka moment for the patient. It's not quite as good as that. But first of all, the cortisone and the lifting away helps them sleep, literally overnight. Their life is changed. And secondly, it gives them some freedom of movement. Not back to how it was originally, but there are various ways of doing it. The radiologist might put a little bit of dye into the shoulder through a needle, check it with an X-ray, then we're talking about 40 mils of fluid, so quite a lot of fluid. And this is where they need their rehab, because they're thinking, I'm getting some movement now, but they probably had this for months. So their scapula's all funny all over the place. They can't get their movement back. They've probably lost a bit of muscle bulk. So they need to have their physio and their rehab to try and get their strength back and their proper movement patterns. Otherwise, the capsule may shrink back down again and they'll be back to square one.
Do swimmers tend to get this?
Sorry?
Swimmers tend to get this.
It's not necessarily something that's sport-specific, because the reason why I put that is more common in diabetics, more common in people with heart disease. It can affect the young. We see two populations, really. The older population who just insidiously come on, and those that do use their arms, who may have mild restriction. Now, some of this may be just posterior capsular restriction, but sometimes it develops into a very slow, insidious frozen shoulder, which then will melt away with the injection. Any questions on that? Happy? Ready for another one? Okay. Yeah.
If you do multiple injections, what are the risks?
Yeah, I'm asked this quite a lot. I mean, what are the risks of keep on giving steroid injections into a joint? To be honest, the main value of that last case is sometimes, if you catch a frozen shoulder early, you can sometimes abort the pain by just giving a cortisone, not necessarily high volume, a cortisone to calm the inflammation down. We don't really know why they develop this, and we don't know the process that drives it. But that is a case. So one-off cortisone injection early might, with physio then, before they've really stiffened up, might help a lot. If they needed more injections, I would actually ask the radiologist or myself not give the steroid, because it's the volume you want in that case. So local anaesthetic and saline. The question about repeated steroids, you ask 10 doctors, you'll get 10 different opinions about how many steroids can you put into a knee or in an ankle or whatever. And I think, a lot depends on where you're going with this. If you're trying to stave off a knee replacement, then actually if you cause a bit of wear and tear to the articular cartilage, it doesn't matter. They're going to have it replaced, aren't they? But if you're talking about someone who's not very in that avenue, I would limit it really down to about 2 or 3. And you've got to ask yourself, why are you giving it? In the world of elite sport, you're under massive pressure to inject a joint to get them to play. Not to inject the morning of a game and play, but to speed up the recovery. So can you calm a knee down that's maybe a little bit synovitic? They've got a bit of articular damage. It keeps on flaring up. You worry about someone who has an effusion in the knee because that turns off their quads and they're therefore more vulnerable to further injuries. Just give me a steroid, doc. I know it calms it down. And that's where you're under, education, consent, all that sort of stuff. So, I remember this patient very clearly because the mother was quite forceful. 17-year-old schoolgirl, very keen swimmer, comes in with her mother. Mother's very concerned. She's a very good swimmer, doctor. She is, you don't understand what I'm saying. She is very good. She's very good. But she presents with a gradual onset of right low back pain for 3 months. She's not told anyone, definitely not her mother. And she gets no night pain, that's reassuring, and she's systemically well. But she gets pain most of the day, worse on carrying her books at school, worse after sport, doesn't seem to radiate into her buttocks or into her legs, so she has no obvious ridiculous symptoms. Mother says, does she need to see a specialist? So if this came into your room, was there anything that you'd ask? Good question, because I was just coming no. But going back to what I said, those 3 things, is it traumatic, overuse and referred? There doesn't seem to be a history of trauma. So this is either referred, well, it's back, so it's probably pretty central, or it's an overuse problem, isn't it? Sorry? Smooth muscle injury? Yeah? Is there a cycle? Good question. Is it cyclical or hormonal or whatever? No, but good question. 17? Yep. Good question. No early morning stiffness. No other joint disease. She hasn't got any small joint problems. She's not had arthritis, inflammatory bowel disease, psoriasis. There's no family history of back pain. Good questions, but no. Excellent. Because we talked about an overuse injury. Why has this happened? What has she done? What stroke does she do? I don't know if any of you got kids who've swimming. I was never really a swimmer, but my daughter was really into swimming. It's the most boring sport you can watch. The number of times I've sat by a pool thinking, I want to die. But these are the questions that you want to ask. What stroke does she swim with? How much swimming does she do? Does she do some ridiculous 17 hours a week swimming? If she's that good, she might be. What is the provocative position she gets herself into? With back pain generally, is it worse flexion, extension? That might give you a pointer. Family history. Are there any red flag symptoms? And what about her? We talked about cycles, very good question. What about her periods? What about her diet? Swimming is one of those sports where they're exposed. You know, they wear a swimming kit. So they're very conscious about their weight, their appearance, their figure. You know, has she been flogged so much with exercise that actually her periods haven't started? Is there a family history of osteoporosis? Does she have some eating disorder? Okay, you're not going to ask that on day one, especially with a mother like that, but, you know, those are questions you might want to think about. So, you examine her. She has a good posture. She has good pelvic control. Do you know what I'm not talking gynecologically here. Do you know what I mean when I say that? Again, tonight, stand with your kit off in front of a long mirror. And if you think about it, when we stand on one leg, why don't we fall over? Well, it's all obvious, isn't it? We're putting our centre of gravity onto that side. So what do we do to do that? We contract our adductors and our glute muscle to hold ourselves stable. If you look at my belt, it's flat when I'm on 2 feet. When I stand on this foot, I hitch this one up. And that should maintain when I do a little knee bend, which is a very rudimentary walk or run. We should be firm around here so we can all be in line. And this has consequences for other medical conditions. Stand in front of the mirror. Have a look at your imaginary belt. Have a look at your knees. And don't think about it, but just look and just do a single leg bend. Are you straight or are you like this? And if you're like that, it's likely that you're actually not controlling your pelvis. Not that you're necessarily weak, but you actually don't use the muscles you should be using. You're probably relying more on your hamstrings rather than your glute muscles. Glute muscles are very important for supporting our pelvis, for driving us forward. Look at the Olympics, the female sprinters. They've got enormous asses, haven't they? That's where their power comes from. They don't tear their hamstrings that commonly. A lot of their power comes from their glutes. So that's what I mean by pelvic control. Single leg snap, are they well controlled? No hip flexor tightness. She's got reasonable good flexion. She can touch, you know, for a 17-year-old, she can touch to her mid-shins. That's not bad. It doesn't seem to be painful. But extension is poor. Oh, God, don't like that. Especially when she twists back to the right. Neural tension, that means nerve tightness. You can test that on straight leg raise, slump, and other neurological examination. That's all normal. And a sacroiliac joint, you examine that, that seems fine. And she hops, oh, that hurts in my back. And she's tender just to the right of L5. So you've done a pretty thorough examination. Impressed mother, look, I'm taking this seriously. What are your thoughts? We know it's we think it's an overuse injury. It's an extension-related back pain. What do you know causes pain in your back when you lean backwards? Facet joints, excellent. For those of you who don't know what the facet joints, I'm sorry if I'm teaching you suck eggs, you've got the vertebrae bodies here, and your facet joints are supplementary joints that support the spine at the back. So when you lean back, they compress and can cause pain. So facet joints, well done. Sacroiliac joint can be a cause of, is quite commonly extension-related. Stress fracture, and less commonly extension-related disc prolapse. Most discs are worse when you lean forward, but about 10% are worse when you lean back, which doesn't necessarily help you, but gives you a pointer. What do you know about stress fractures? I was never taught about stress fractures at medical school. I didn't know what they were. Does everyone know what they were? Are you happy to know what they are? Everyone happy? Or do you want me to explain? Okay. Basically, bones aren't solid. They're made out of honeycomb appearance. Hence, they're light, and therefore we can move around. If a bone is put through stress, and it's usually a torsional, rotational movement rather than a little bit of a flexion and extension, then at a low level, under load, the cross bridges between the honeycomb appearance within the bone start to break, and you bleed within the bone. You can't see that on an X-ray, but you can on an MRI scan. You can see blood, fluid within the bone that shouldn't be there, and that's painful. It's uncomfortable. Most people carry on. If, however, you carry on doing the provocative action and increase your load and training, then more and more of the fractures extend to what's one of the cortexes, where the periosteum is. And that's far more painful, as you know. If you've broken a bone, you know how painful it is. And that's called a stress fracture when it comes to one of the cortexes. When it's just within the bone, it's called a stress reaction. Usually people can't exercise from then, it's too painful. But some people have, and they've then sheared all the way through, and that's obviously a fracture. So you have a spectrum of normal, stress reaction, stress fracture to fracture. And it's just overloading the bone that can't cope with what you're doing. And it may be that they're running more, swimming more, or they have poor biomechanics that are causing the bones to twist. In the back, you have a stress fracture, stress reaction of the pars interarticularis, the part of the bone that goes from the body of the vertebrae towards the facet joint, that area there. And you can either have just one of them fracturing off, or both of them, in which case the whole thing slips forward and you get a thing called a spondylolisthesis. But it is painful, and you can diagnose it by scans and all sorts of funny things. But this girl had a unilateral stress fracture of a right L5 pedicle. My God, does she need surgery? This is managed, this will heal, as long as she has the right ingredients to let it heal. So the offloading, the right chemistry, biochemistry within her bones, the bone density, the hormones, the diet, all those sort of things need to be addressed. And in these cases, we might check vitamin D, we might check bone density, maybe not in a 17-year-old, but certainly older athletes we would, certainly females. And we would treat this with looking at her load, which has probably been excessive from the swimming. She's been pushed to do it. Maybe she's been doing some land-based drills, strength work, which has been stressing her back, too much poor technique. But also looking at her muscle strength and her muscle length, which is might be pulling her into extension all the time. These will get better, anything from 6 to 10 weeks, but it needs an education. And the important thing of these is if you don't catch it early, then it heals by fibrous union rather than bony union. And this is important to tell the parents this, because guaranteed this mum, she'll need an X-ray later on in her life, let's say 5 years later, and some very clever radiologist say, oh yeah, see you had a stress fracture when you were younger. What do you mean? Well, I can see the line. Hasn't it healed? Well, it's healed a bit. Oh my God, that doctor was useless. He said it was healed and I got her back to swimming. So you've got to tell them that actually it heals by fibrous union, so it'll always be visible on an X-ray or a scan, so that you're covering yourself later on in life in case she decides that you were incompetent. Happy with that? Any other questions about backs or stress fractures? Most of the good question. They were looking into stress fractures, and you probably need an MRI or some of that type of imaging to actually diagnose it, because you're looking for the bone edema, the bone bruising. They decided they would see whether stress fractures was common in football. And so they scanned all the FA Academy, aged 13 to 18, and 25% of them had asymptomatic stress reactions in their back. What makes your back stressed in football? Especially extension. And they realised it was the heading practice. So it's not necessarily the impact load, it's the extension. And in swimmers, the butterfly is very provocative. So you're looking at what population get this? The gymnasts, the dancers, the cricket bowlers, the tennis players, all those people that extend their back, often unilaterally or asymmetrically. Confirmed it on MRI, yeah. 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 And then you say, right, we don't do any more scans, like a fracture. We treat it purely clinically. So you look at the provocative maneuver position, how painful is that, how, their level of discomfort, and you're purely pain-driven by how their pain offloads, and then you slowly build them up. Talking about overuse injury, as a rule of thumb, you can only increase your stress or load on the body by 10% a week, 10% increase. So that load may be how far you're running, how fast you're running, the slope you're running on, the surface you're running on, if you suddenly go from grass to tarmac. Those sort of things need to be taken into account. Most people, come February, March, we are inundated with people with stress fractures as they're preparing for the marathon. They go on the internet, right, you got to do this, you got to do this. 4 weeks before the marathon, you do a long run. Right, so they've potted along at about 12, their long run once a week is 12 miles, then 13 miles, then 15 miles, and they're doing really well. And then this internet advice says, right, you've got to do one long run 4 weeks before the marathon, 3 weeks before the marathon. So they go from 15 miles to 20, 22, 23, and they break down. Why did you do the long run? Because it told me to. So I wanted to know how it felt. Don't worry about it. When you go out in the marathon, there'll be thousands of people there cheering you on. The adrenaline will get you through. If you then get a stress fracture at the end of the day, you can recover from it. But now you can't run the marathon. So you've got to offload. So it's all to do with load. You've got to preparation is key. You've got to have time to do it.
Can I just ask you a question at the bottom there? Because we probably would refer a girl like that to a physio first.
Fine.
So what would you do if they...
Well, I think you're right. You've got to confirm the diagnosis, and depending on how long it's been there, I would then advise the patient, the parent, about what the future looks like in terms of, yes, they can get back to full sport. Yes, they need to regrade themselves slowly. Yes, it may be always apparent on an X-ray or some imaging in the future. And then I would monitor them with the physio, because we work side by side, to say, listen, how we progress from there. Quite reasonable to send them to a physio, that's fine. But often, if you're not sure of the diagnosis, you might need imaging to sort that out.
You're talking about exercise, prescription in general, increasing exercise.
Yeah.
I tell all my patients to start swimming.
Yeah.
Because I love swimming.
Yeah.
But I realise I don't know if I'm really helping them, because people have such bad technique or...
Well, that's the same for any sport. You tell them that I love tennis. Okay, play tennis. But they find they're coming with a shoulder problem because they've decided they've been serving 300 serves when they haven't done one ever before. So like any sport or any activity, you've got to build up slowly so prevent the overuse. And at the end of the day, we're all different. So our technique may be really bizarre, but if it suits us and we don't get any problems, crack on. If someone enjoys swimming and they don't get any problems, just build up slowly. Be sensible about it. And yeah, it's horses for courses. So that's fine. Yeah, I'd much rather they cracked on with activity, and if they get a bit of a hiccup, then offload, look at your technique, get some advice, and go on from there. But like I said on that one of those first slides, they come back to say, oh, my shoulder starts aching. Okay, have you fallen or injured it? No. It's not traumatic. Is it referred from the neck? No. So this is an overuse problem. What have you done? And that's what takes the time. What have you done? Yeah, I've just swum. Yeah, tell me, how long have you swum? What stroke did you do? How many lengths have you done? Oh, well, I usually swim twice a week, but now, we're on holiday, so I swam every day. Well, that's more than 10%, isn't it? You don't have to blame them. You say, that's the reason. Okay, let's offload. Let's get you nice and strong again. Let's get the shoulder back to how it was and just build up slowly. If I can do it, it's not rocket science. How are we doing for time? How much longer have we got? Okay, should we do this one more? You all right with this? I had 10 cases, so we haven't gone very far. Okay, 16-year-old schoolboy, not very sporty, is brought in by his dad complaining of anterior knee pain in the front of his knee. Came on gradually, so it wasn't a sudden event. Very localized to the center of his patella. No radiation, doesn't spread anywhere, and no swelling. Occasional feeling that it might give way, but never actually does. No clicking or locking. No trauma. Sorry, I put that there. No trauma. Any thoughts going through your mind? Yeah, good question. Excellent question. Sorry, I preempted it. What makes it worse? Well, I don't like going up or downstairs. It hurts, especially going downstairs. It's worse when I sit for a prolonged period of time, especially when I get out of the chair. And he's grown a lot recently. Good question. Why is that important? Yes, I mean osteochondrosis is not specific to a growing problem, it's that age group. But the thing about growing is that when we grow, our bones grow much faster than our muscles and ligaments. So relatively, we're like a bow in a bow and arrow. We're taller, but our muscles are much tighter. So they might have a consequence on traction injuries, or they might have a consequence on literally how your limbs behave because they're tight. Excellent. Excellent. Anything else? Patellar maltracking is a proposed diagnosis. Top of the class. Any other possibilities? Yeah, osteostatus. Osteochondritis we mentioned. Pretty good. I don't know what I've got there. Osteostatus, yes, well done. There's another one called Cindy Larson-Johansson, which is the top end of the patellar tendon, so at the lower pole of the patella, as opposed to lower down towards the tibial tuberosity. Patellar tendinopathy. And we say tendinopathy and not tendinitis. Tendinitis is an old-fashioned term. It's for people as old as me. So it's tendinopathy, because we know that if you've had a tendon problem for more than 3 months, there are no inflammatory cells there. So you can't call it a tendinitis. Patellofemoral Syndrome, otherwise known as chondromalacia patelli, patellar maltracking. Fat pad impingement. Ever heard of that? It's nothing to do with obesity. Are you aware of what that is? That is underneath your patellar tendon, below your kneecap, is basically polyfiller, fat pad, that fills that space. Just a bit of padding, basically. But it has a large nerve supply. And if you overextend your knee, then sometimes in some people, their kneecap patella digs into the fat pad and causes localized bruising, which is very uncomfortable. And actually, it's people who overextend their knees. So people who run with an overextension, or people who extend their leg quickly. And we see it quite a lot in swimmers who actually do tumble turns and then kick off the wall and extend their legs. And they get anterior knee pain. It's very easy to diagnose. You just put their leg into flexion and let it flop into extension. And they, oh, that's my pain. And they point to it just below their patellar tendon. Sometimes difficult to manage because you want to restrict their extension. You want to lift their patella up. We do inject it, but you don't want to inject many steroids into the fat pad because it shrinks it down a lot. So you've got to be very careful how you manage that. But this could be referred, couldn't it? It could be referred either from their hip. So all problems in the knee, especially in kids, could be coming from the hip until proved otherwise, or it could be coming from their back. So you examine him, and he's a chunky young lad. He has a valgus posture, not need. He has poor squat control. We talk about that single leg. He was all over the place, couldn't control himself. Not untypical in that age group. But you examine his hip and spine, and they seem pretty much normal. His knees were cool, they were dry, there was no effusion, and stable. There was no fat pad impingement and no meniscal signs. Looked all pretty good. But you looked at his muscle bulk, his VMO, the inner quad, was as weak as anything and wasted. ITB, do you know what the ITB is? Iliotibial band? It's a band of fascia, gristle, that comes from the outside of the pelvis down the outside of the leg. And that is something that works as a strut to support ourselves. And if that's tight, then it pulls our leg outwards and our patella outwards. And he had a mobile patella. He had very excessive wobbly kneecaps. And he was tender under the medial aspect of his patellar facet. But there was no obvious patellar tendon abnormality. So what do we think he's got? We think he's got Patellofemoral Syndrome. In other words, a malalignment issue of his kneecap. If you look at a model of a knee, the back of the patella has a little ridge which fits in a groove. And the idea being is that when we bend our knee, it runs up and down the groove. What controls our kneecap? Our quadriceps. Where do our quadriceps come from? Not from there. They come from here. So for all of us, there is a tangential pull across the groove. So to compensate, our inner quad should fire in a split second before our outer quad and be stronger to pull it in the groove so everything moves up and down in alignment. Anything that compromises that movement pattern will make the kneecap move side to side. And it was felt that the pain was due to trauma of the knee, back of the kneecap banging against the front of the knee. And obviously that can happen, but the majority of these patients, certainly at this age, get no trauma. Their pain is generated by the vast amount of nerves that are around your patella, and that's why they can't be specific. When you get nervy pain, you don't say, it hurts me just there, doctor. You say, well, it's bit there, bit there, bit there. And this condition, they can have pain in the front of their kneecap, medial, lateral, even posterior can be referred, because it's a nerve-related pain. And this young lad, he was tight into his structures, so everything was pulling his kneecaps out. He was knock-kneed. So again, it's difficult to fire your medial quad when you're like this. You're much more dominant on the outside. And when he stood on one leg, he just fell into valgus like this, because he had no control through his bum. And he had mobile patella. Okay, you can't change that. But you can tighten up, you can loosen off the tight structures with the massage, and you can get him strong, and stretch the tight structures and get him strong. So you want to control the movement of the kneecap and reassure him he's not damaging himself. This is quite common. But let's address the issues, watch your load, build up slowly, get you strong, do lots of stretching, and move on from there. Any questions? I won't bore you with any more. But this is the sort of thing I do. And as I say, we see a lot of people who perhaps may originally have been referred to surgeons because that was the only avenue available to you. But if you want a non-surgical route, then there is an alternative. Unfortunately, not on the NHS nationwide. I think that might come if there's more money in the NHS. Probably not. It's not as important as heart attacks and strokes. I totally recognise that. But there's a reasonable size of morbidity where people want to get back to what they do. Any questions?
Are you covered by insurance?
Yeah.
Good question.
Yeah, definitely. That's all to do with the GMC specialist recognition. The insurance company said there are probably 200 sports physicians who may be GPs with an interest, but actually a bit like yourselves in terms of appraisals, revalidation, all that involves. Once you're on the specialist register, then the insurance company will cover you. So we have 8 sports physicians, probably 40 physios, and then all the other ancillary staff as well. Any of you interested, you're very welcome to come and look at the clinic. Very happy to sit in, and if you want to see what we do, very welcome. If you want me to come to your practice and bore you again for another hour, very well happy to do that as well.
Where are you clinic?
There's one in Rains Park, which is associated with the David Lloyd gym there. I don't know if you've ever been there. It's a massive place, 16 indoor tennis courts, massive. There's one Kensington, the local one here, which is just by Sainsbury's on the Cromwell Road. Then one in the city, in Threadneedle Street, and one in Canary Wharf. Hyperbaric oxygen. Yes, I mean, it's like a lot of things in sports medicine. It's right on the verge. I mean, we're very poor at research in our field of medicine, so having evidence base is limited. But the trouble is when you've got an elite sportsman who has to be back, and you don't think you're going to do any harm, then it's done, and then you set a trend. That's how are you familiar with PRP, injections of blood? That all kicked off by an American footballer who had a week to get back from his injury for the grand final. So they injected blood into his lateral collateral ligament and he played. Wasn't that amazing? The fact that he wore a knee brace at the same time, no one recorded. So it's driven by public demand, patient demand. And the idea being is you flood the body with high pressure oxygen and it helps healing. Well, I've done that with players. To be honest, it's, you need to do 2 hours twice a day. It's big demand and it's not pleasant. Does it help? I don't know. Does it do any harm? No. So if you've got time and money and availability, yeah, do it. There are papers written about it. Thank you very much.